Hi, this is Amber from the Ohio State University. I'm going to talk about a very important topic which has the potential to affect not only the TORS outcomes, but also the entire oncologic and functional outcomes of oropharyngeal cancer patients, preoperative planning, and exposure for TORS. First head and neck clinic visit is the most important visit in terms of deciding which patients are going to be the best candidate for transoral robotic surgery, radiation, or chemoradiation treatment. After making your first evaluation with the already existing biopsy results, CAT scan of the neck, and anatomic details in the CAT scan, and using the MP scope in the clinic, you can get good amount of information about the tumor and the exposure and other comorbidity factors that helps the patient to decide which way the patient is going to go. Even though HPV-related oropharyngeal cancer patients are younger and healthier patients, still more than half of these patients are heavy smokers, and we can still see significant comorbid conditions in these patients too. So we have to take all these comorbid conditions very seriously preoperatively before planning the surgery. This is the list of some of those comorbid conditions. This slide summarizes the 8 T's of endoscopic and robotic access: crowded teeth and narrow mandible and limited space in the oropharynx. It certainly affects the excess and no teeth and edentulous patients. Access can be easier. Trismus, especially in a previously treated patients, can be a problem that should be evaluated. Transverse dimension of the mandible is so important. You need that space for exposure while you put the retractors in, especially for deeper tumor location like base of tongue and supraglottic larynx. Mandibular tori, usually they are small and shouldn't be a problem. Uh, but tongue, if it is a large tongue and glossomegaly, those patients can have hard exposure. And you need to tilt of the neck while you are extending the neck during especially deeper tumor locations in order to get more horizontal view to the floor is important, and you need that flexion. Treatment prior radiation or chemoradiation treatment can always be challenging for mouth opening and for the stretch of the tissues while retracting. And the tumor, especially the primary tumor location and the size of the tumor is important. You have to see the entire tumor while doing the TORS surgery, so it is an important factor to consider. And adequate to suboptimal robotic exposure related studies. In the recent years, we have there are few good studies about these, and one of them showed that mandibular body height can be a significant factor. If it is 2.6 centimeters versus 2.2 centimeters, it can be adequate or suboptimal. And the hyoid mental distance is an important factor too. If 5.5 centimeter or more distance is available, that is usually a good sign. And neck circumference having more than 42 centimeters can be a challenge situation while doing the transoral robotic surgery. Another significant study about this topic came from Jefferson, and restricted TORS exposure can be predicted with some of the measurements on the head and neck imagings. One of the measurement is soft palate to posterior pharyngeal wall distance less than 8 millimeter can be a problem. and hyoid and posterior pharyngeal wall distance less than 30 millimeter, and also epiglottis and vertical laryngeal plane angle of less than 130 degree can be a prediction of restricted transoral exposure. This is one of our TORS candidate patients that we have taken to the OR to do panendoscopies, transoral robotic surgery, and neck dissection. But after the panendoscopy and application of the retractor to expose, we understood that it was not going to be possible to do our robotic surgery due to the exposure problem. So I just wanted to apply the previous imaging criteria to this patient to see whether we were able to uh, evaluate this patient in the clinic with the imagings to for exposure related problem and just identify this patient in the clinic without taking to the OR. As you can see in the sagittal image, that the soft palate distance to the posterior pharyngeal wall should be around 8 millimeter, but this is around 5 millimeter, and even the lower part was touching to the posterior wall. And the hyoid body distance to the posterior pharyngeal wall again should be more than 3 centimeter, but this is around 2.5 centimeter or so. When you look at the angle of the vertical angle of the larynx to the epiglottis, it is 110 degree. Ideally, it should be over 130 degree or so for good exposure. One another criteria uh, should uh, that should be helpful is that hyomental distance. And if it is more than 55 millimeter, that would be helpful. In our patient, this was around 50 millimeter in length. For most of the tonsil cancer patients, Crew-Davis mouth gag might be good enough to get exposure. But with the extension of the tumor towards the inferior part of the tonsil, towards base of tongue, or supraglottic area, or in the hypopharyngeal tumors, you need to have these special mouth retractors like FK retractors and the flex retractors, similar function it can give. So you use these retractors in order to reach the deeper parts. The more we try to open the mouth gags vertically, the more we lose the space in the hypopharyngeal area. So especially in the deeper parts, like in the hypopharynx and supraglottic larynx resections, we have to limit the mouth opening, and we have to bring the angle of the blades of the retractors to more horizontal angle to get a little more space in the hypopharynx. Just like exposure-related factors, tumor-related factors are also very important while selecting the patients. These are some of the best candidates for TORS: exophytic tumors, small tumors in the tonsillar region are really good. But if the tumor is involving more than one subside and the palate and field cancerizations are happening like in the second picture, those are not the best transoral robotic candidates. This is another example with a heavy smoking history, young patient, 40 years old, but unfortunately disease was involving multiple sides, uh, palate, tonsil, and limited base of tongue involvement. This is not the best candidate for surgery, especially in the setting of extranodal extension involving the upper neck lymph nodes and clinically almost like a conglomerated lymph nodes, fixed lymph nodes. Any patient having TORS contraindications should be avoided for surgery. Retropharyngeal carotid is an important one, and the tumor involving the midline tongue and involving bilateral neurovascular uh, lingual arteries an internal carotid artery and the carotid valve involving tumors and encasement of these structures should be avoided. And functional contraindication if resection of more than 50% of base of tongue might not be the best function afterwards. And resection of the tongue base and the entire epiglottis can be a problem too. And oncologic contraindications are T4B diseases, unresectable neck disease, multiple distant metastasis, neoplastic related trismus, and involvement of the prevertebral fascia, mandible, hyoid, and the tumor having significant soft tissue and lateral neck involvement, and eustachian tube and nasopharynx involvement are other contraindications, and those should be avoided for TORS. Some of the examples of TORS contraindications, and to be honest, surgery contraindications too, involvement of the internal carotid artery, encasement of it, and involvement of the prevertebral fascia in this patient. This study not only shows the example of retropharyngeal carotid artery for us in image A, but also moving carotid artery in image B when you see the left common carotid artery is moved to the lateral from medial. So in different times, the imaging shows different location of the carotid artery. So as TORS surgeons, we have to be aware of this and we have to be careful about our posterior and lateral incisions. While making those incisions, we need to see entire tissue we touch. We shouldn't be doing any blind incisions to the retropharyngeal area or lateral pharyngeal area. Since the salvage surgeries often necessitates mandibulotomy, pharyngotomy, free-flap reconstruction, tracheostomy, and it has uh, high complication rates and poor oncologic outcomes, these patients are poor candidates for transoral robotic surgery, and very selective patients can be a candidate for TORS. In conclusion, preoperative planning and evaluation for TORS exposure are so important for the success of transoral robotic surgery and also functional and oncologic outcomes of the entire treatment. Thank you for joining me today for this important topic. Thanks for your attention. Have a good day.